All right, so as Nestor already said, the topic is surgical treatment of medically refractory epilepsy in children. And somebody in the audience already said this has a signature of Dr. Mathern. So let me just start with the basics. The goal of epilepsy treatment is really no seizures and no side effects. And this is really something that a lot of neurologists and neurosurgeons got together back in 2000 as part of an NIH conference to meet and sort of brainstorm about what exactly is the definition of curing epilepsy. And no seizures, no side effects is the goal that they came up with. And there was actually a subsequent meeting in 2007 to follow up on those goals along with new goals. So I won't get into those, but for the developing brain or the pediatric patients, the goal really is to eliminate seizures as soon as possible to optimize the cognitive development and improve the behavior and quality of life. And this is really something that the ILAE, or the International League Against Epilepsy, got together and developed specifically for kids. And this is just to show you there is actually a lot of developing brains to be saved, just because epilepsy has a bimodal peak. And so predominantly in kids and then much older later in life in terms of higher age groups. And this seems to be holding up across different countries and across different industrialized countries. So a few more definitions. And these will matter in just a little bit. Idiopathic epilepsy is presumed complex genetic and usually age-dependent epilepsy. It is ideally only epilepsy with no underlying structural brain lesion, and all you're dealing with is epilepsy and no other comorbidities. Symptomatic epilepsy then are epileptic seizures that are the result of an identifiable structural brain lesion, so something that you should be able to see on some kind of neuroimaging. And then cryptogenic then is somewhere in between, whereas epilepsy usually with focal features, both clinical features and EEG characteristics. But unfortunately, the structural problem has not been able to be identified, so it's neuroimaging negative, but focal features. So we think there's an underlying reason for the epilepsy, but we just cannot see it. And so the reasons why these categories matter is that even though cryptogenic makes up the majority of the epilepsies, it is, where's my arrow? There we go. It is not the category that's most intractable. In fact, the symptomatic ones, the symptomatic epilepsies are the ones that are most likely to be intractable, even though it only makes up 19% of the epilepsies. And less of the symptomatic epilepsies are in seizure remission or complete seizure control. And so that's usually the worst off category that we're dealing with. So what happens when you try to treat epilepsy medically? And so this is just to show you the seizure medications in untreated new onset epilepsy patients. And this is a pretty well-known Quan and Brody study that came out in New England Journal of Medicine. So what they found, again, completely new onset epilepsy patients, the first seizure medication can get seizures under control in just about half of the patients, so 47%. By the time you get to the second AED or second anti-epileptic drug, the success rate goes down to 13%, so significant drop already. By the time you get down to the third seizure medication, it's down to 1%. If you try some polytherapy, the success rate is only 3%, and so what you're left with is a little bit more than a third that are not seizure-free.
Does that mean you're adding an additional AED or you're switching?
Adding. So looking at this, again, new onset, you're dealing with a third of the patients that are not under medical control. And if you look at the timeline of medical intractability, This category is often what we're dealing with in the pediatric neurology clinic. So the youngest of the kids, they tend to be what we call catastrophic, and they remain intractable. They get to intractability fast, and they remain intractable. The focal seizures, however, which may come later in life and more in the adult population, can sort of simmer along and chug along, and sometimes we lose track of how intractable it really is and how many medications we've tried, and so it's something that we need to be diligent about. So it can drag on for years, over decades sometimes. And so when you then look at what happens when you already have treatment-resistant epilepsy and you add on more seizure medications, what are the possibility of success rate? And so this is a combination of many studies of just about 5,000 patients. And we see that when you add on a new drug, only 5% become seizure-free. 35% of them have a more than 50% reduction in seizures. 21% will have actually more seizures versus the 39% with placebo. 8% will exit the trial, and 0 to 2% will actually die during the trial, or just about 1% per year in terms of morbidity. And so this is just to show you that once you become treatment resistant, again, the idea is you can add more medications, but not a whole lot. More seizure control will come about. What happens when you try vagal nerve stimulator then? And these are for kids with treatment-resistant epilepsy again. And again, it's a combination of multiple studies with about 2,000 patients. And again, the seizure-free rate is quite low, only at 4%. A little bit more than half of the patients will have a 50% reduction in seizures. 33% will have a little bit more. 11% will exit the trial, and again, the mortality rate is 1% per year, just like the previous trial. So does it matter when we look at pathology and etiology? Does it matter in terms of seizure control? And so the top line is again mostly new onset cases, and we see that the category that's most likely to be seizure-free are the strokes and the vascular malformations, and hippocampal sclerosis is the group that is least likely to be seizure-free. And again, this is new onset cases, but by the time you get down to hospital referral, and mostly to a tertiary hospital like UCLA, almost every rate is less, meaning we are getting more of the treatment-resistant epilepsy patients. And hippocampal sclerosis, in terms of seizure control rate, comes down to 11%, 24% only for the cortical dysplasia. And so this is quite a bit of treatment-resistant epilepsy. So then let me switch topics a little bit. What are the risks of uncontrolled seizures? Why does it matter? And so the first problem with uncontrolled seizures is you end up with microcephaly, and it's pretty clear why, because brain growth happens in the first few years of life, predominantly in infancy and toddler ages. So if there's any process that disturbs brain growth, you could end up with microcephaly. Here's another example from Chandra et al. In 2007. These are actually twins with tuberous sclerosis that he was looking at. So they're identical twins. Twin A, again, they're with TSC. She was 6.5 years of age when this MRI was taken. She actually has never had seizures. She, compared to normal patients, had normal total cerebral volume, total gray matter volume, and total white matter volume. Her twin didn't fare as well. She, again, has TS. This picture was also taken at the same age. She started really early on in life with infantile spasms, which was followed by complex partial seizures. That was so intractable that she had a left frontal resection here at 2 years of age, which gave her complete seizure freedom. But when you look at her total cerebral volume compared to her twin, with just a couple years of seizure, her total cerebral volume, gray matter volume, and white matter volume were significantly decreased. In the same study, they expanded that idea out to patients other than TSC. And so again, this is normal, this is cortical dysplasia, age-matched. The cortical dysplasia patients started having complex partial seizures at 5 years of age. That's cut off. The TS patient here started having infantile spasms at 6 months of age, and again followed by complex partial seizures. And their cerebral volume is also decreased, more so in the child with TSC and with earlier onset of seizures. So then the second problem with uncontrolled seizures then is something called epileptic encephalopathy that we're always concerned about in pediatric neurology. So this is a group of disorders in which patients with frequent uncontrolled seizures or frequent interictal EEG activity are at risk for progressive cognitive problems and neurologic disabilities. So these could be developmental delay, mental retardation, autism, learning disorders, you name it, they are certainly a higher risk for that. It is believed that the epileptiform abnormalities interictally contribute to the progressive disturbance in their function. So not only the seizures, but also the interictal abnormalities can also contribute in their neurologic problems. And most of these are age-related, so predominantly pediatric population, and affect the immature developing brain. And this is just to show you that an IQ test shows you that infantile spasms is, kids with infantile spasms tend to have the lowest full-scale IQ compared to other seizure types that are considered a little bit more benign. And in fact, if you look at the full-scale IQ, it's been found to be associated with, again, the type of epilepsy, infantile spasms in particular, and that's why we tend to call it a catastrophic epilepsy type or epilepsy syndrome type. Younger age at seizure onset, again, contributes to a lower IQ, and at least in this case, is less than 1 year of age. Seizure frequency, so more than one per day or daily or multiple daily seizures, also lowers your IQ. Longer seizure duration, so the more number of years that you have uncontrolled seizures, the more likely you're going to end up with a lower IQ. And then again, the more than 3 anti-epilepsy drugs, I think, just says how intractable these patients' epilepsies are. And then the third problem with uncontrolled seizures then is mortality. And this is a cumulative effect. You see that from 1 to 14 years of age, and all the way on up to into the 70s, mortality goes higher with uncontrolled seizures. So this is a third problem that we're concerned about when it comes to uncontrolled epilepsy. So having said that, then, we know that pediatric patients with uncontrolled seizures can have microcephaly, they can have epileptic encephalopathy, and developmental problems and increased mortality. When do we then refer a pediatric patient over to a surgery center? So for all patients, persistent generalized or persistent partial seizures after failure of 2 to 3 anti-epileptic drugs, which we saw earlier, if you add on more drugs, it's not going to help as much as the first drug. And this is especially important if there's more than 1 seizure per day or at least daily seizures for all patients. For kids under the age of 2, an urgent referral, again, to prevent the developmental delay and the epileptic encephalopathy that we saw earlier is especially important. And then there are special circumstances where we're talking about temporal lobe epilepsy, cortical dysplasia, tumors with seizures, again, tuberous sclerosis. Most of these deserve special considerations, but probably sooner than later in terms of referral to a surgery center. What is pediatric epilepsy surgery and how does it differ then with the adult population. So again, age at seizure onset here for pediatric patients, you'll have the majority of patients will have had their seizure onset by 2 years of age. So 60% by 2, 45% or so by a year of age. Age of surgery then does not have that similar pattern, which tells you that the surgery usually comes quite a bit later than the seizure onset. The etiology for epilepsy surgery patients in adults predominantly is hippocampal sclerosis, followed by tumor, cortical dysplasia, and then less so the vascular, the trauma, the encephalitis, and the Rasmussens. In kids, it's quite the opposite story. You have the cortical dysplasia as one of your most common etiologies. That's followed by tumor and stroke and atrophy. Hippocampal sclerosis really only accounts for roughly 8%, and tumor sclerosis about 5%. So the etiology is quite different in terms of pediatric and adult. Let me skip that for now. So in terms of surgical procedures for pediatric patients then, a lot of them are temporal. So about a quarter of them are temporal resections, followed by hemispherectomy, frontal resections, and a more palliative procedure of a vagal nerve stimulator. This is just to show you that temporal resections tend to be tumor, followed by hippocampal sclerosis. And again, the cortical dysplasia group, the most common etiology group, tends to be frontal hemispherectomy and multiple lobar resections. Even within the pediatric populations, there is a difference in terms of surgical procedures. So the youngest age group, hemispherectomy and multilobar are one of the more common procedures. And again, the etiology there is 60% cortical dysplasia. Once you get to the older teenage group, it becomes more lobar and focal resections, and the tumor etiology starts to come up compared to the youngest population. Then when you look at seizure outcomes, again for treatment-resistant cases, we're talking about 68 to 75% seizure freedom when you look at the resective cases. When you look at the palliative cases, which includes corpus callosotomy and vagal nerve stimulator, you're really talking about 4 to 6% seizure freedom rate. So the resection rate is significantly better in terms of seizure freedom. So I wanted to show you what the ILAE found in 2004 in terms of what the different centers actually use for evaluations for these patients, both in terms of resective in blue and palliative procedures in yellow. So it looks like MRI is the highest. Almost all centers use MRI. Video EEG and scalp EEG is right up there with MRI. Then followed by a drop in, and basically a difference among the different centers of whether they use SPECT, FDG PETs, functional MRI, MEG or MSI. This is a WADA test, and intracranial invasive recording. When you look at then the same survey then looked at different centers in terms of United States versus Europe and Australia, again MRI, video EEG, and scalp EEG are almost used universally. But the United States tends to use more of the SPECT or the PET, more of the PET here. And there is also more intracranial electrode placement, more WADA, and a little bit more of the MEG. So it looks like the United States tends to use more techniques than compared to the European and the Australian centers. What's also interesting, if you look at specifically intracranial electrodes by, again, by region or by geographic location, the intracranial electrodes tend to be used more so in the United States, even with definitive MRI lesion compared to the European and Australian counterparts. And USA also tends to do more palliative procedures compared to their European and Australian counterparts. So the last topic that I'm going to switch to is what do we do here at UCLA in terms of the...
Is there any data regarding the impact of using those images in the success of the surgeries? Because it seems that there is quite a difference between Europe and the United States. Do you have any data regarding the success of the United States versus Europe in the treatment of epilepsy, and that could be attributed to the imaging studies?
It's very institutional dependent.
All the situation has changed since 2004. In the sense that MEG, for instance, is more popular in out of date.
So I was going to tell you about what we do here, at least on the pediatric side. So we certainly use the video EEG. So all patients come in for basically 3 basic tests: the video EEG inpatient, telemetry. Everyone gets an FDG PET. Everyone gets an MRI. And when we think it's useful and appropriate, or if the above 3 tests are either not agreeing or are vague, we tend to go towards MEG or MSI, which is magnetoencephalography or magnetic source imaging. And then Noriko Solomon in neuroradiology has been wonderful, and she's been doing the co-registration, combining the FDG PET and the structural MRI to tease out any subtleties. And so what we don't do a whole lot of is functional MRI, although we certainly rely on that when when we need to figure out where language is and where to avoid in terms of resections. We use some WADA. Again, for language localization. We really don't use any SPECT because it's just not. Here we use pretty much all FDG PETs. And at least on the pediatric side, I think I remember 1 case in the last 10 years, maybe 2 at most, that we implanted electrodes. And so a big difference in terms of comparing to other U.S. centers and even to basically worldwide other centers. And so how I wanted to show you a little bit of the MEG like you were bringing up. So we've been relying quite a bit on MEG, especially in kids with tuberous sclerosis complex. And so this is just to illustrate to you the structural MRI, and these are all tubers. So MRI tells you where the locations are for these tubers, but they don't tell you which one is the one generating the seizures. And the same goes really for the FDG PET. It shows you the hypometabolic regions all over here, but again, it does not tell you which one is the culprit tuber. So MEG, at least in our experience, has been quite helpful and quite useful, and at least in a lot of kids, it's been able to localize to one tuber or one group of tubers, so that we've been able to target specific regions. And oftentimes we, at least in this small series, we find that MEG may be more useful than ictal and interictal video EEG. The other technique that I already mentioned is the fusion or the co-registration of the FDG PET and the structural MRI. So this was also published in 2006. And this is to illustrate to you, again, this is a child with tuberous sclerosis complex. What Noriko is trying to do here is show you the actual tuber here on the structural MRI. But this whole entire area was hypometabolic on the PET, and so that's when the fusion became really useful. This child went to surgery. Electrocardiography in the OR showed quite a bit of abnormality over the entire region, and so that area was completely resected. And besides the tubers here, what was thought to be normal on the structural MRI was actually cortical dysplasia. So that whole entire area was dysplastic. And so using these two techniques then, how do we fare in terms of seizure outcome? And so this was just earlier this year. Again, in tuberous sclerosis patients, we are able to reach 67 or just about 2/3 seizure-free rate, which is to me, pretty remarkable that we don't use intracranial electrodes and we're able to reach 2/3 seizure-free rate. And I think Dr. Weiner, who was here not too long ago, his much larger series also was about 2/3 seizure-free rate with multi-staged and often bilateral invasive recording. Another study, so focusing then on the fusion or the co-registration in terms of how helpful it is in teasing out the areas of cortical dysplasia. Again, Noriko was able to go back and look at those results in about 82% seizure-free rate using the co-registration in specifically the cortical dysplasia patients. And again, overall then, I think this is about to be published in paper, but online right now, is a study that compare the so basically the UCLA pediatric epilepsy population, comparing the pre-1997 group to the post-1997 group, where more of the techniques have been used in the latter group, including MEG and the FDG PET MRI co-registration. The overall seizure freedom rate in the latter group is about 77%. And so, minus the 19 at the 2-year out mark, so that's 58. Am I doing the math right? So to summarize the multiple areas that I've mentioned, there's a large proportion of epilepsy that occur in childhood within the first 2 years of life. After 3 seizure medications, seizure freedom is pretty unlikely. We're down to the single digit. Intractability is most likely in the symptomatic epilepsy group. Intractability or uncontrolled seizures then leads to 3 problems, again, microcephaly, encephalopathy, and increased mortality. Then it would make sense when seizures become intractable to consider surgery earlier on rather than later in life to try to save these developing brains. We saw that VNS and calosotomy offer about 5% seizure freedom rate. And in comparison, the surgical resections, when we can offer early, is anywhere from 68 to 75%. And again, what we do here at UCLA is about 77% overall, using the MEG and the fusion techniques. And I think I'm running early. Just to thank everybody in the pediatric epilepsy program, so headed by Dr. Sankar, but really spearheaded by Dr. Shields much earlier on. And the current members are Dr. Lerner, Matsumoto. Suyudavin has been instrumental over the years and over the decades in terms of coordinating the surgical process for us. Sylvia and Sarika wanted to mention because they are the ketogenic diet team members, which is completely different topic, but I wanted to acknowledge them. And certainly Noriko Solomon, who has done a lot of the imaging work that you saw, and certainly Gary in the back. I think I'm going to end there. Yes?